All right, here's our objectives for this lecture. Like I said, make sure you're reviewing them for exam purposes. Some recap. Remember, acute heart failure is when heart failure can develop suddenly, for instance, after a heart attack or due to certain heart rhythm problems. Chronic heart failure usually develops gradually over time as a result of a different medical problem, such as permanently high blood pressure. This slide should look really familiar because it was on the other slides. Remember, chronic heart failure is a progressive worsening ventricular function and chronic neurohormonal activation that results in ventricular remodeling. This process involves changes in the size, shape, and mechanical performance of the ventricle. So, chronic heart failure causes enlargement of the chambers of the heart, resulting in changes in normal electrical pathways. Patients with heart failure are also at risk for ventricular dysrhythmias, which remember we talked about with our different rhythms, how through the rhythm interpretation, if you have, as your heart muscle stretches and moves, it's the pathways that the signal is going to transfer to is going to be a little different, and that could cause arrhythmias just from that. Remember, like AFib is numerous sites of atria fire spontaneously rapidly. The organized atrial depolarization no longer occurs, and thrombus formation is promoted, and patients are at risk for strokes. We've talked about that before. Treatments with anticoagulants, cardioversion and ablation, and antidysrhythmic drugs. In both acute and chronic heart failure, the body's response to low cardiac output is to mobilize compensatory mechanisms to maintain cardiac output and blood pressure. Remember I said we talk about it later? This is the later. Some compensatory mechanisms, they're initially helpful because the goal is to increase the cardiac output, but after time becomes harmful. The workload, preload, and the O2 of the heart is increased in an already failing heart. So basically the heart's struggling, so your body goes through and basically does some compensatory mechanisms to help increase the cardiac output, which basically you already have a heart that's not working, is now working even harder. So you're just causing potential more. It's injuring yourself more in the long run. So the overloaded heart uses compensatory mechanisms to try to maintain adequate cardiac output. The three main compensatory mechanisms are neurohormonal responses made up of the renin-angiotensin system and the sympathetic nervous system. Then you've got ventricular dilation and ventricular hypertrophy. So the renin-angiotensin-aldosterone system is a hemostatic regulatory system. When activated, results in blood pressure control and fluid and electrolyte balances. In response to stress, fluid and sodium is retained, causes vasoconstriction and increases blood pressure. Some of this should be familiar, I believe, in your heart discussions in the first semester. Talk about the renin-angiotensin system. So remember, the role of the system is to increase the blood pressure when it becomes too low by activating angiotensin 2. Angiotensin 2 causes vasoconstriction and helps increase the blood volume by causing the kidneys to conserve sodium and water and triggering the release of aldosterone and antidiuretic hormone. So if you think about it, as cardiac output falls, the blood flow to the kidney decreases, and this is sensed as decreased volume. So what this is doing is now, since the kidneys feel like doesn't have the appropriate volume, the SNS is activated to increase blood pressure and heart rate. It releases aldosterone from the adrenal cortex that results in sodium and water retention and increased peripheral vasoconstriction and increases your blood pressure. Your pituitary gland stimulated and releases ADH, which results in water reabsorption. So, like we've talked about, your heart's already failing, has poor output. So now your body is basically forcing your heart to fight harder because it's increasing the blood pressure and increase your heart rate. To remember, your cardiac output is your volume by your heart rate. So increases your heart rate, and then the pressure, by increasing your vasoconstriction, increases your blood pressure, which then increases your pressures to your kidneys, which your kidney then feels like it's got the appropriate volumes. Other factors contributing to the development of heart failure is there's endothelium is produced. This further causes atrial vasoconstriction and increases cardiac contractility and hypertrophy. And then you've got your pro-inflammatory cytokines are released in response to cardiac injury, which further depress heart function by causing hypertrophy and contractile dysfunction and cell death. So like I said, so endothelin and the pro-inflammatory cytokines, those are what those are what causes the remodeling of the ventricles to cause a hypertrophy for like we talked in the previous lecture regarding the how you increases the mass, so it increases your cardiac output, but it decreases the volume. And so your SNS is activated by inadequate stroke volume and cardiac output. So a decreased blood flow is sensed by baroreceptors in the aortic and cardiac bodies. The sympathetic nervous system is then stimulated. It releases catecholamines, epi and norepi, which increases your heart rate, increases your contractility, and it enhances peripheral vasoconstriction. So here's another way your SNS is actually now trying to increase your heart rate and increase your contractility and those things as well to help increasing your cardiac output. So, and then eventually ventricular remodeling occurs. So this is continuous activation of the neurohormone responses, causes ventricular remodeling, hypertrophy, and ventricular myocytes are large, abnormally shaped contractile cells. And the altered shape leads to impaired contractility and increased ventricular mass, wall tension, and oxygen consumption. Remember in the previous lecture we showed the ventricles on diastolic heart failure where they're just a lot larger, a lot thicker cell walls. That is a result of the continuous activation of the RAS and SNS systems. So they're large, but they're less effective in pumping. Remember, they're big muscles, so they can squeeze hard, but they can't relax, so you can't allow a lot of volume in. So remodeling can cause life-threatening dysrhythmias and sudden cardiac death. Some drug therapies to prevent and reverse remodeling and decrease mortality are recommended. ACE inhibitors, beta blockers, and aldosterone antagonists. Dilatin. So here's some more remodeling. Dilatin starts as an adaptive mechanism to cope with increasing blood volume. The enlargement of the chambers of the heart that occurs when pressure in the left ventricle is elevated. The muscle fibers of the heart stretch in response to the volume of the blood in the heart at the end of diastole. Remember, we talked about the other way the heart can go is either increase the muscle mass or it can dilate out to stretch like the balloon. Initially, it's effective, right? Because it increases the cardiac output and maintains the blood pressure perfusion. Like I said, so if it's stretching out in the beginning, like when you first blow up a balloon, it stretches out and it squeezes back in. But eventually, it becomes inadequate and cardiac output decreases because the muscles start getting overstretched and can no longer contract effectively. That's like we keep going back to the balloon, right? You keep blowing it up wider. Eventually, it doesn't close as tight as it used to. So an increase in muscle mass and cardiac wall thickness in response to overwork strain slows the process, takes time for the increased muscle tissue to develop. Initially effective, increases contractile power of the muscle, the fibers, leads to increased cardiac output and maintenance of tissue perfusion. So this is, like I said, so we went from dilating to now to hypertrophy, which we've talked about, where it takes time, but the muscle tissue is developing. It's, officially it increases your output, but eventually the muscle tissue starts taking up too much of the area. Eventually, hypertrophic heart also leads to poor contractility, increased O2 demands, poor coronary artery circulation, and risk for dysrhythmias. Like we've talked about this several times now. So dilation refers to the size of the filling space. Hypertrophy refers to the thickness of the muscle. See, like here's, for example, a large area. This is the dilated areas here, where the ventricles here. This is definitely thickened. You can definitely see the difference in the area, the volume that these can now hold. Okay. Some other things, a counter-regulatory mechanism is attempted through the release of natriuretic peptides. So you got your atrial natriuretic peptide, your AMP, and your BNP. Those hormones are produced by the heart muscles. They're released from overdistended cardiac chambers, released in response to increased cardiac volume in the heart. So basically, while your kidneys and your SNS are now trying to increase your cardiac output, your heart's like saying, well, this is too much, we need to dial it back. So they're releasing these hormones right now. and basically they will cause some diuresis, vasodilation, and lower your blood pressure. So it kind of it's their way to kind of balancing out and maintaining that homeostasis. So the combined effects of ANT and BMP counteracts the effects of the SNS and the RAS system in a patient with heart failure. So all these mechanisms of heart failure have been referred to as the vicious cycle of heart failure because low cardiac output leads to multiple mechanisms that make your heart work harder and worsening the heart failure. Compensated heart failure, it occurs when compensatory mechanisms succeed in maintaining adequate output that is needed for tissue perfusion. So like I said, if there is a balance between the SNS and the RAS system, and then the different hormones your heart's producing, the AMP and the BMP, somewhere they find that happy homeostasis balance, you're going to be in compensated heart failure. Decompensated heart failure is when those mechanisms no longer maintain output and you start having inadequate perfusion again. There's two types of systems that are classified the heart failure. You just have to be aware of the systems that exist. You don't have to know all the different stages and classifications of these two of them. So the New York Heart Association classifies people with heart disease based on the tolerance to physical activity. The American College of Cardiology Foundation that identifies disease progression through treatment strategies. Also, it helps identify people that are at risk for developing heart failure. So both of them do different staging systems as a way to track people with heart failure. So determine, treat, and cause. Our primary goal is to determine and treat the underlying cause. So using that, you're going to do an echocardiogram. It provides information on your ejection fraction, the structure and function of the heart valves and heart chambers. Remember, that's how you have to decide. That's how they go to. That's one of the tests that are used to figure out if you're left or right-sided heart failure. Some other tests, ECG, right? So you can check to see the rhythm, chest X-ray, 6-minute walk test, cardiopulmonary exercise tests, heart catheterization, endomyocardial biopsies as well. Some lab studies used during the initial workup: your electrolytes, your BUN, creatinine, liver function test, thyroid stimulating hormone, CBC, BMP, and a routine urinalysis. The BMP levels correlate positively with the degree of left ventricular heart failure. So that's going to be your big test for heart failure. Your internal prohormone is a more precise test to aid in the diagnosis of heart failure. Levels are temporarily higher with patients receiving Netroside, but can be high in patients with chronic stable heart failure, right? Because, like I said, so BMP is released when there's more stretch and stress in the heart, remember? So, because that's its counter-regulatory measures against your body having, increasing the rate and the cardiac output. BMP can be increased by other conditions, though: PE, renal failure, or acute coronary syndrome. The BMP level is a key diagnostic indicator for heart failure. High levels are a sign of high cardiac filling pressure and can aid in both the diagnosis and management of heart failure. So some medications you guys should be familiar with. I'm not going to read them all off to you, but you've got here's a good list of those and kind of what they've been used for. Your different medications. Once again, just list them out. Some IV medications that you should be very familiar with. Like I said, it talks about the some side effects of them too. So be sure, for example, like your digitalis improves contractility, but you want to monitor digitalis toxicity, especially with patients that are hypokalemic. So it's important to pay attention to those things. Treatment of patients in the elderly, gerontologic considerations. They may be present with atypical signs and symptoms such as fatigue, weakness, and somnolence. Decreased renal function may make older patients resistant to diuretics and more sensitive to changes in volume. And administration of diuretics to older men requires nursing surveillance for bladder distension caused by urethral obstruction from enlarged prostates. So just some things to think about with your elderly patients. Nursing process: care for the patient with heart failure. Your assessment: your focus is effectiveness of therapy, patient self-management. Your sign system: increased heart failure, so you're going to be a lot of teaching, emotional, psychosocial response, You're going to be, take a good health history. PE is you're looking for your pulmonary edema. So your mental status, we talked about before, your lung sounds, crackles and wheezes, heart sounds. We talked about all these different signs, symptoms of pulmonary edema in the last lecture. Activity intolerance, excessive fluid volume related to heart failure syndrome, anxiety related to symptoms, paralysis related to chronic illnesses, and ineffective family therapeutic regimen. Some different diagnoses that are used. Collaborative problems, hypotension, poor perfusion, cardiogenic shocks on chapter 14, dysrhythmias, thromboembolisms, pericardial effusion, and cardiac tamponade. Care for your goals, promote activity, reduce fatigue. Ultimately, your goal, pretty much for every patient, is to try to get them close to some sort of baseline or to normal levels. So relieving fluid overload symptoms, decreasing anxiety, and helping them manage their anxiety. Encourage the patient to verbalize his or her ability to make decisions, and educate the family about management and therapeutic regimen. Bed rest for activity intolerance. Bed rest. What are you going to do for a patient that has activity intolerance? You're going to bed rest. Encourage physical activity 35 minutes daily. Exercise training, pacing activities, wait 2 hours after eating. Avoid activities in extreme hots or colds. Modify activities and positioning. Elevate the head of bed to facilitate breathing at rest and supporting arms. Fluid volume excesses. We've talked about a lot of these things over the years too. Assessment of symptoms of fluid volume overload, daily weights, eyes and nose. Diuretic therapy. So things to think about diuretic therapy is timing of meds. Make sure you're not giving your Lasix at 9 at night right before they're going to bed. That's just no fun for anybody. Fluid intake, fluid restriction. Do they need do you need to be on a fluid restriction if they're drinking too much and they have too much fluid volume excess? Maintaining sodium restriction. Teaching the patients about all their medications. Low sodium diets. I know a lot of this stuff you heard in second semester as well. Monitoring for signs of excessive fluid, hypotension, stress management, prevention of infection. Know how and when to contact a healthcare provider. That's important, right? You want to make sure they know exactly what they're calling for and when to call. So they don't either call for no reason, but they also, more importantly, they don't call because they don't think it's important when it is important. Include the family in education. End-of-life considerations. Heart failure is a chronic and often progressive condition. Need to consider issues related to end-of-life when palliative or hospice care should be considered. Cardiogenic shock. So shocks will be discussed in a later lecture, but just know there is a cardiogenic version of shock. Symptoms of heart failure, shock state, and hypoxia. So it basically, decreased cardiac output leads to inadequate tissue perfusion and initiation of shock syndrome. There is the thromboembolisms, right? So if you have decreased cardiac output, you're going to have decreased circulation. You're going to run the risk for DVTs and patient with cardiac disorders. You got pulmonary embolisms. Blood clots from legs moves through obstructs the pulmonary vessels. So some things to make sure you're looking for is dyspnea, pleuritic chest pain, tachypnea, cough. Treatments can be your anticoagulation therapy, unfractured heparin, low molecular weight heparin. This is something you guys shouldn't be vaguely familiar with already. Pulmonary emboli, like I say, here we go. This is just emboli that have happened. It's a picture of it, of how it can occur. Pericardial effusion, cardiac tamponade. Pericardial effusion is the accumulation of fluid in the pericardial sac. Cardiac tamponade is the restriction of heart function because of this fluid, resulting in decreased venous return and decreased cardiac output. Clinical manifestations are ill-defined chest pain or fullness, pulsus paradoxus, engorged neck veins, labile or low blood pressure, shortness of breath. Just here's how you assessing findings of cardiac tamponade. Treatments, you got pericardiocentesis, which is basically you puncture the sac and aspirate the fluid. Pericardiotomy, which is under general anesthesia, a portion of the pericardium is excised and to permit the executive fluid. Basically, it's just allow the fluid to drain. Sudden cardiac death or cardiac arrest, right? Emergency management, you're going to go to your CPR, your airway, breathing, circulation, defibrillation for VTAC or VFib. And that sums up part 2 of